I would like to talk about the severe tricuspid regurgitation. The tricuspid valve has for a long time been named the forgotten valve, but due to the increase of use of transcatheter valve technologies and transcatheter technologies in structural heart disease, we have seen an increase in interest in this so-called forgotten valve. Why is it so interesting? We have a large population of patients due to functional TR, either after left heart surgery, mainly valve surgery, or after pacemaker implantation or functional right heart failure, who are not treatable in another fashion. They can only be treated in a medical way, so they can be treated with diuretics, they can be treated with certain therapies, but there has been no sufficient therapy to really relieve the symptoms in the last years. Surgical option in these patients is not a very good one. The mortality is really high because, as I mentioned before, those patients tend to have a pre-operation already in the heart on the left side. They're severely ill. They mainly suffer from kidney failure. They have ascites, they have peripheral edema, and they have highly elevated liver enzymes. So they're not the kind of patient you really want to treat surgically. So if we look at the tricuspid valve, then we might understand why it is so difficult to treat the tricuspid valve. First of all, it's a multiplanar valve, so it's not in one plane. The cusps, the leaflets, in contrary to the mitral valve, are rather small. They differ a lot in their anatomy, and because of the dilatation of the annulus, you will see that the coaptation of the leaflets is quite big. I might want to show this in a short video. Here you see the typical anatomy with a huge right ventricle. And if you look here at the leaflets, you can easily appreciate that the coaptation is not closing, it's quite big, and this of course causes a major problem when treating this valve. If we look at the different possibilities of addressing the valve, we can differentiate either in treating the annulus, we can treat the leaflets, we can try to decrease the coaptation, and by this decreasing the tricuspid regurgitation itself. Or another option is to put self-expandable valves in the vena cava superior and inferior, the so-called CAVI treatment. If I might go through the different options, I would like to start with the coaptation treatment, which has been very successfully already started on the left side, mainly the mitral clip, but other technologies are also there to come. If we transfer this to the right side, we are having a problem with the coaptation because, as I showed, the leaflets are not getting close to each other, and you can imagine that it's getting quite difficult to catch and to grasp the cusps with a device. Nevertheless, it has been done successfully. We know that if it succeeds, then the success rates are quite high. We might need more than one mitral clip, or in this case tri-clip. It has been modified a bit by the company. But this really depends on the anatomy of the patient. Another attempt is to decrease the circumference of the annulus, which means that a band, in this case it's mainly the cardio band that has been used, but other technologies are also on their way, will be anchored in the annulus, and finally the annulus will be decreased in its dimension by closing the cardio band, and by in this way trying to bring the valve dimensions back to a rather normal shape and dimension. Also, this of course has its limitation. First, we had to learn that the annulus of the tricuspid valve is much bigger than the mitral valve. And on the other hand, we also saw that the right coronary artery is of course in a very close proximity to the annulus. The third solution is to put two self-expandable stents and valves, self-expandable valves in the vena cava inferior and superior, and this is a model from a right heart as it has been printed. So these valves will be put there in order to not touch the native valve, and they will stop the backflow into the caval system, and by this will help to recompensate the patient without touching the native valve. If we look at the advantages of this trick valve system, then this can be placed even if a pacemaker is there, which is a main limitation to many other technologies, but the pacemaker is in a high number of patients present. I would say in 75% of the patients that are target for this kind of therapy, we will have a pacemaker lead in situ. Yeah? So in general, all of these technologies are in an early stage. We are having the first clinical trials. I think the biggest question for the future, or the biggest adventure, will be to find out which therapy is optimal for which patient cohort. We will have to see when in the course of the disease we should optimally start treatment. There are new data suggesting that we should start quite early in the course of disease, because of course the patients that are treated now are patients with a long history of right heart failure. So those are severely ill patients, which of course make it more difficult to establish the question of prognosis. We know that we can relieve symptoms. I think this we have already learned, but I think now the main question will be which patients do benefit, when do they benefit, and when we should intervene in the course of the disease.